whereas very early stages, single or less than 3 nodules, each less than 3 centimeters. And intermediate stage, if it is beyond this and multinodular without any portal vein invasion or hepatic extrahepatic spread. In all this, liver function should be preserved and the performance status should be 0. And whereas in advanced stage, portal invasion or extrahepatic spread, if it is there, then it is advanced stage, and liver function should be preserved. For that, we'll see child score ABC. AB is okay if it is C and it is compromised liver function. So, and performance status also we'll see 1 or 2. In any case, if it is beyond this and terminal stage, it is called end stage. So first, we have to see the size of the lesion and how many lesions are there. If it is less than 3 nodules and less than 3 centimeters, up to that, we can go for ablation treatment. If at all resection or transplant is not possible. So there are certain criteria for that. Um, if very early stage, if the patient is potential candidate for transplantation, we have to see any CLD features are there. That means rise in portal pressure or altered LFTs or like that. Then you can go for liver transplant if there are no contraindication. But if there are any contraindication to liver transplant, then ablation is better, because if resection, patient may not be able to tolerate that resection position. So ablation is minimally invasive, and if in cases of less than 2 centimeters, it is completely curative. In early stage also, if good ablation zone is there, then it is curative. If it is beyond that, then it is intermediate stage. For that, we can do TACE. That is, we'll not discuss about this test. And if at advanced, there is only systemic management. So I would like to present some cases which we did the ablation procedures in different case scenarios. So this is a case of large SCC in the right hepatic lobe. After that, we did TACE, and then we did portal vein embolization to make the right lobe atrophy, because surgeons are planning for right hepatectomy uh, after the TACE and portal vein embolization, because tumor will shrink and portal vein embolization will cause the left lobe hypertrophy. So, in the with aggressive curative intent, we planned for uh, right hepatectomy. For that, we did TACE. After 4 weeks, 4 weeks of TACE, we did portal vein embolization. This is the portal vein embolization, and then after that, I will tell you. This is portal vein embolization. So first, we punctured transhepatic and cannulated the portal vein. This is the portal venogram, which is showing both right and left branches. So our aim is to embolize the right branches. So this after that, through SIM catheter, we introduce the microcatheter and we have taken the angiogram. So after that, right side branches are embolized, and rest of the right main portal vein and its branches also embolized. So after that, in follow up, what happened is, patient after 4 to 6 weeks of follow-up, we did a CT. The main lesion is shrunken significantly, but a new lesion developed in the left for B area, for A or B in that region. So only one lesion is there, and after portal vein embolization, because of cutoff of portal vein supply to the left lobe hypertrophy, this will cause the, if any foci of SCC are there, it will cause more proliferation of the residual or indolent small, which are not visible in imaging. They'll try to grow more aggressively. So this happened in this patient, and a small lesion appeared in this segment 4A or B area. So for that also, a planned embolization, microwave ablation with good coverage and a follow-up. There is no residual lesion. A patient was followed up for 3 months But after 3 months, what happened is he developed multiple lesions. So just he was kept on chemotherapy and just followed up. So this is one case scenario because we tried with aggressive intent, because sometimes only if right is there, even if the large size tumor, hepatectomy may prolong the lifespan of the patient. But in this case, but whatever we do, patient is getting recurrent lesions. So after that, this is another case scenario. This is a patient with colorectal cancer for which colectomy was done. But after 1.5 years, patient developed a small lesion, which is PET avid, and some small subtle hypodensity in the contrast venous face is seen. This is confirmed with MRI, and there is also subtle small lesion is seen. No, this is not here also seen, but it is not seen in CT, because this is not these lesions are not visible in plain CT and plain ultrasound. We first did lipidoid test. There is another option, surgical hepatectomy, but surgeon felt it is difficult, and the patient also willing for minimal invasive therapy. So as it is difficult to see in plain CT and ultrasound, we did lipidoid test so that it will stain the lesions, and then we can ablate it under CD guidance. So this is the lesion, first lesion through microwave ablation, microwave probe. We ablated first lesion, and while coming also, we adjusted the probe such that we pointed at this and we ablated the lesion. This is the follow-up MRI where there is no obvious no enhancement, and this is also no enhancement. Only some peripheral enhancement is seen. Patient was followed up, and we for some 3 to 6 months. After that, he didn't develop any new lesions. So this is case scenario for metastatic colorectal cancer. Because in metastatic lesions, generally we go more aggressively to treat any lesion. If any small lesion is there, go more aggressively. Okay. So in this, we actually we have not given irinotecan. We have given normal doxorubicin, epirubicin only. After that, we did ablation. So another this is another case scenario. Uh, patient uh, uh, patient has a known SCC, for which test was done previously. Uh, so after 1.5 year follow-up, lesion was seen with some peripheral irregular and nodular enhancement, which was not there in the previous imaging. So as this contrast enhancement is new and it was somewhat irregular, so it is considered as recurrence, and there is a mild elevation in the AFP also. So we did ablation for that, and after follow-up MRI showed good ablation zone without any residual lesion. Okay, so this is another case scenario uh, where there is a large tumor, about 8 to 9 centimeters tumor, and at that time only there is a small lesion in the left second segment, second also there is small lesions. So so we just for like a palliative, we went ahead with the test for the right lesion, and if at all patient is good, then plan for ablation of second this segment 2 and 3 lesions. Patient was test was done for this patient, and patient was kept on lenvatinib. But within some 3 months, patient showed significant good response with significant decrease in the size of the lesion and no enhancement in the lesion. So with a positive intent, we went ahead with the left lesions also ablation. So we ablated that with good margin zone and no residual enhancement. Uh, Patient was kept on follow for 3 months, and so patient was didn't develop any new lesions. So patient was planned for right hepatectomy. Uh, right hepatectomy. Okay. So this is another case scenario. Um, uh, So this is simple. First, we found some lesion which is about 2.5 centimeters as a single lesion. So with a curative intent, we did microwave ablation. Uh, After follow-up, CT showed good response. So while doing these different case scenarios, while doing ablations, first we have to see the size criteria. Generally, up to 3 centimeters and up to 3 nodules, we can do ablation if they are amenable for ablation. So, and we have to see the next, we have to see the any adjacent structures, mainly any large vessel is there, like portal vein or any artery, mainly to avoid the heat sink effect. Uh, so because of heat sink effect, this tumor may not get ablated completely. So in this scenario, micro ablation is better, but it will also have some heat sink effect. So uh, if at all any large vessel is there besides the lesion, better to go with microwave ablation. So it will have, because it will have less heat sink effect, so that we don't have any. We will have less chance of residual lesion. And if it is adjacent to the uh, biliary gallbladder or any colon, then we can do hydrodissection and then we can ablate it. In that type of case scenarios, better to use radiofrequency ablation, because with microwave ablation, uh, more risk of damage to the adjacent structures will be present. Okay. So this is regarding ablations. Next, if at all, mechanical thrombectomy for acute strokes. So generally, patient comes to the emergency department with the typical, sometimes atypical stroke symptoms. Then, after assessing in ER by um, ER physician or neurologist, if it is stroke code is activated, then we'll first do what CT, first preferably CT. If it is hemorrhagic, then it is sent for the new stroke care. If it is ischemic, then we'll see um, what is the aspect score and what is the size of the infarct, and if there is any large vessel occlusion or not. If there is no large vessel occlusion and infarct is small, if the patient comes within 4.5 hours, then IV thrombolysis is done. If there is a large vessel occlusion and there is an infarct, then we have to go for IV thrombolysis with or without mechanical thrombectomy. But certain criteria needs to be met, like size of the infarct. Generally, they'll give one third of the territory of or about 70 to 100 ml of the infarct. If less than that, and NIHS score. If at all they are met, then we can go for um, with if it is less than 4.5 hours, then IV thrombolysis is given like bridge therapy, and then we can go for mechanical thrombectomy. For If it is after 4.5 hours, then, and if it is amenable for mechanical thrombectomy, then mechanical thrombectomy go. But after 6 hours, if there is a, and between 24 hours, then we have to do advanced imaging like CT and MRI perfusion, and we have to see the penumbra in this. If penumbra is significant, then we can go for mechanical thrombectomy. So these are few cases of mechanical thrombectomy. This MRI images I don't have, so I'm presenting this DSA images only. This is a patient with right hemiplegia and right deviation of mouth and NIHS score of about 10. Um, in CT, there is a cutoff in the MCA, and in fact, is small aspects is around 6/7. So immediately we took for the DSA. It is around a window period, that means after 5 hours. So we took immediately for the mechanical thrombectomy without any IV thrombolysis. After that, through this red aspiration catheter 7 2, we aspirated the catheter. So immediately it was decanalized with good TC3 decanalization, and the patient improved very well after the procedure. So this is another case scenario. This patient presented with right hemiplegia and right deviation of mouth with the power of about 1 bar 0, both upper and lower limbs, and there is an infarct in the um, basal ganglion and few cortical areas. Uh, and patient has come after some around 4 to 5 hours. So we took for the mechanical thrombectomy. Uh, this is the M1 MCA cutoff, left M1 MCA cutoff. So it's like with aspiration technique, we aspirated the clot and the good recannulation was seen. And while doing the angiogram of carotid ulcer, we found a plaque in the carotid artery. So for as this patient only MRI was done, MR angio, it is cut off as there. So we have taken for the procedure. And the patient is a known case of um, chronic kidney disease. That means this nephrotic syndrome, which has a high proteinuria. So he is in a hypercoagul state. So we thought maybe because of that, this might have happened. But there is a large plaque in the carotid bifurcation, which we thought of this may be the culprit for the lesion. So after that, patient was kept on antiplatelets, and patient clinically he was improved. But power it is around 0/1 only, but sensorium everything he is improved. And after 1 week he was discharged. So this is another case scenario. This patient presented around with altered sensorium and uh, with altered sensorium mainly, and presented to the ER department around after some 5 6 hours after the episode. And CT was done, which MRI was done, which showed multiple infarcts in the cerebellum, bilateral in the right cerebellum, and also in few areas in pons and medulla. So as it is posterior circulation, we immediately took for the DSA, which showed cutoff in the uh, right vertebral and basilar artery. After that, through the aspiration technique, um, we aspirated the clot. So some decanalization of the basilar artery and the PCS were noted, but this artery is severely diseased with multiple irregularities and multiple stenosed areas. Even right vertebral artery also showing uh, stenosed areas. Next. So this is the final picture, which showed satisfactory recanalization with multiple stenosed areas. Uh, we waited for a half an hour. This lesion is not closing. So after half an hour of waiting, check angio showed good recanalization, satisfactory recanalization with good forward flow. So we stopped this procedure, and patient has some deficit, but slowly his consciousness, altered sensorium was improved very much, and uh, a few additional infarcts have happened, but overall, not much significant deterioration in the clinical condition was noted. So in posterior circulation, uh, we can do even after 24 hours if we think that it is beneficial. Because in posterior circulation, if entire thing is occluded, then his pons, medulla goes, so many vital structures will be there. So patient life will be risky. So for that, we can go if there is a good amount of brain tissue, then we can go for mechanical thrombectomy even after 24 hours. So this is so we'll end that stroke topic. The other case just for if, so this is a case of a lesion in the left kidney upper pole region. So this is angiomyolipoma, and patient is having pain. So he came for embolization. So we did angiogram, and we did embolization with the PVA particles. And this is the post procedure. Um, this is post closure angiogram, we showed complete obliteration of the left angiomyolipoma. So patient was followed up, and there was no recurrence, and it was shrunken in size. It was shrunken in size, and that pain complaint, everything was uh, improved. So just this case actually is from international patient. Some bullet injury or some injury has happened to this patient. After that, they did hepatectomy and they did some surgery for which no good history was there. So in imaging, what we found is um, there is a collection in this, and because of they occurred this, and there is some bile leak. For that, we have kept a pigtail catheter outside, uh, and the patient was good with this also, and everything is correct. But still, it is still even after 3 months, 4 months also, there is a drain coming from this. So they want some specific surgery, and so what we did is first, because this anatomy is very, as I said, very dirty, and we don't know correct anatomy. So first we want to know the anatomy, and then pigtail drainage. So this is very minimally dilated system. So in this type of minimally dilated cases, what we can do is in ultrasound we cannot puncture correctly because we don't know. We can identify the mild small ducts, minimal dilated ducts, but so what we can do is in fluoro. From around 10th, below the 10th rib, and project pointing the needle in this direction, that is superior and medial direction. So we can puncture it, and slowly we can retract the needle by injecting the contrast. Minimal contrast you have to inject. So at a point of time, we'll hit this bile duct. So we can do the angiogram. By doing the cholangiogram, we can see the ducts, and we can also make the ducts dilated. But in this case, because of severe fibrosis, they are not much dilated also. Even after mm, for putting the catheter also, 6F, some only 6F pigtail we have put. Even the 8F, it is not going. So we have kept the catheter, and we, we asked the patient for a follow-up, and the catheter, it was draining well. So patient was kept on catheter, and actually it was planned for surgery, but this surgery is difficult, so they deferred the surgery, and patient was kept on this tube for 6 months. After that, patient, I think, lost to follow up because he was an international patient. He didn't come back. So if minimally dilated, we can do the fluoroscopy technique by blindly puncturing and slowly retracting. So somewhere we can hit the this biliary duct. Then we can do angiogram, and then after that we can puncture. If necessary, we can repuncture also. So this is the anatomy of this patient, because there is a cutoff because there is surgery. There are multiple strictures here. In this, there is no obvious leak. Um, but patient is having some mild collection here. Recently, it was reduced, so we did a PTBD angiogram, as a surgeon wants to know the anatomy to plan for surgery. But because of this anatomy, surgery was not done. Only PTBD was kept, and the patient was set. So okay, so this is another case. This is a case of 19-year-old patient underwent liver transplant, but after some 2.5 months, something 1.5 to 2 months, patient developed some pain and elective were rising. So immediately we did Doppler. In this, hepatic artery was not seen, so we did a CT angiogram. So there is a hepatic artery cutoff. So this is the cut. So immediately it was planned. It was planned for uh, mechanical suction of the thrombus, and if necessary, thrombolysis, catheter-directed thrombolysis. So this is the um, ciliacular angiogram. We showed there is a cutoff in the right hepatic artery, because the left hepatic was ligated. So there is cut off. After that, we went into that right hepatic artery. So there is no filling. So we crossed it. We tried to aspirate as much as possible. So some mild recannulation has happened. So after that, uh, so recannulation. So we kept the catheter in situ and we thrombolized for about 20 hours with altiplus around 0.8 ml per hour. So we kept the patient in monitoring, CBP and INR, APTT, and fibrinogen levels. So after 20 hours, we have taken for angiogram. We showed complete recannulation. After immediately we removed the catheter and just we did angiogram, and it showed good recannulation with good perfusion of the liver parenchyma. And the surgeons were very happy. This is recannulated. So thank you.